Good afternoon, everyone. My name is Hilda Leon. I'm the Program Manager for the Perinatal HIV Prevention Program. This program is funded by the Florida Department of Health in collaboration with the University of South Florida Center for HIV Education and Research. Our goal is to decrease the number of HIV-infected babies born in Florida. I would like to welcome you and thank you all for supporting the perinatal HIV prevention community by logging on to our third quarterly webinar. I'm pleased to be with you today and so excited to have the opportunity to introduce our guest speakers, Beth Sudduth and Holly Beaver. Beth is the HIV/AIDS Surveillance Program Manager at the Florida Department of Health in Pinellas County, which is located in St. Petersburg, Florida. In addition to the many responsibilities that come with her previously stated position, Beth also chairs the Area 5 Perinatal HIV Task Force, which encompasses Pinellas and Pasco counties. The task force is a group of community-based key players whose goal is to identify and coordinate care for HIV-infected pregnant women in their community with the ultimate goal of having a healthy negative baby. One of those very important key players is our second speaker, Holly Beaver. Holly is a senior registered nurse at USF Health, Pediatric Infectious Diseases in St. Petersburg, Florida as well. Holly coordinates and maintains clinical care of HIV-infected pregnant women and the follow-up care of their exposed infants. This is no easy task. As a longtime member of the Perinatal Task Force, I know for a fact that Beth and Holly, this is a true labor of love. So without further ado, I turn this over to Beth Sudduth and Holly Beaver.
Thank you, Hilda, and good afternoon, everyone. The very first person I want to thank is you, Hilda, our facilitator of this webinar. She was with us in the trenches back in 2002 when the very first perinatal task forces were being created here in Florida. My predecessor, along with Hilda, were meeting with healthcare providers, hospital staff, and health department leaders to educate everyone on perinatal transmission and creating tools to help eliminate that risk factor for HIV. One of the tools they envisioned was creating a perinatal task force that pulled together people and departments that were previously working individually on HIV-positive pregnant females and using their expertise to help one another accomplish a unified task, which is to get the mother into prenatal care, get her tested for HIV, and if she was positive, to get her on antiretroviral medication as early as possible. So that comes to my introduction. I took over the Perinatal Task Force here in Pinellas County in 2006. My background is as an HIV/AIDS Surveillance Program epidemiologist and manager. Our interest as surveillance is to ensure that we report complete information on the pregnant women who test positive for HIV, as well as report information on their HIV perinatally exposed babies. So it comes as no surprise that it is in our best interest to be a part of a perinatal task force, whether we create one in our own areas or we be at least a part of one to gather the information that we need. I will talk more about how we went about creating our perinatal task force here in Pinellas further in this webinar. But first, let me also introduce and welcome my co-presenter, Holly Beaver, who is the perinatal nurse coordinator at USF Johns Hopkins All Children's Hospital. She's going to share her expertise later on in the presentation and how she contacts the HIV-positive pregnant mothers and establishes a relationship with them with the goal of hopefully getting them into prenatal care at our local high-risk OB clinic. In addition to linkage, she also assists the medical staff in convincing the mothers of the importance of taking HIV antiretroviral therapy throughout their pregnancy and later after pregnancy while they are treating and testing the baby. So my starting off point is to share with you this article that was written in the MMWR Weekly back in 2006, around the time that our local perinatal task force was taken over by the current team we have in place. Even at that time, it was very clear that the most important thing we could do was to reduce the perinatal transmission of HIV infection in pregnant women. It was a huge achievement to see how antiretroviral therapy, introduced in 1996 as a treatment for HIV pregnant mothers, had a huge impact on reducing HIV transmission and saving babies from a lifetime of HIV disease management. So how exactly does one go about creating a successful perinatal task force in their community? Well, we are going to talk today about all the pieces of the puzzle and how it can be done. First, you need to educate providers and community health care leaders on why it's important to have a perinatal task force. That requires that you first educate them about HIV if they're not aware, and if they are part of the choir, then you can share with them the statistics of your community, state, and world, and show them the impact of how avoiding HIV transmission in the first place should always be our highest goal. We are here to prevent HIV transmission. Our secondary role is to treat the disease if we are healthcare providers, or report the disease if we are epidemiologists. Second, after you have hopefully created an understanding about the epidemiology and statistics behind the transmission of a disease, you want to approach the partners that have the greatest need to work with you and your task force team. That usually includes people that work directly with or report on mothers who are pregnant and who need to be tested for HIV. We will talk more about which specific people to approach in a few minutes. Next, you want to make sure that you identify pregnant mothers who either have a previous history of HIV or who need to be tested for HIV once they're pregnant. This requires working with healthcare providers that see pregnant mothers and making sure they understand the laws about HIV testing. Well, once those mothers are tested for HIV, and if the tests come back positive, it requires linking those HIV-positive mothers into services. This usually involves surveillance offices hearing about HIV-positive tests through their electronic reporting lab services and contacting the providers to ensure they understand how to link the pregnant positive mother into appropriate HIV services. Holly and I will touch more on this later on. After the mother has been linked into HIV high-risk services, then there needs to be management of not only her pregnancy, but also her HIV treatment, as it can be different for each woman depending on the resistance she might have to the various antiretroviral medications that are available. And finally, there needs to be management of the delivery of her child and the antiretroviral treatments that should be given to not only the mother, but also the baby after birth. At the end, we will discuss some of the case studies that we have come across over the recent few years to show that there is a wide range of issues that the Perinatal Task Force team discusses each time they meet to try to assist these pregnant mothers on what we hope is a path to a successful outcome of a negative baby. So first, we need to educate. Well, who do we educate? Well, first you want to talk to the healthcare providers that have direct contact with pregnant mothers who either need to be tested for HIV or have HIV and need to be linked into high-risk OB care. So begin reaching out to your local OBGYN doctors as well as the nurses and staff that work with them. They are the first ones that are going to see a pregnant mom, and they need to talk with those mothers about HIV testing if they are not already HIV positive. You also want to educate your local birthing hospitals to make sure that OB staff and social workers are aware of policies and procedures on how to handle a mother who comes into their hospital with an HIV diagnosis or one that has not recently been tested in her last trimester and needs to have a rapid HIV test. We will talk about that later as well. And then you want to include infectious disease staff so that they know to call you if they have an HIV patient that they now know to be pregnant. These are women who we call in Florida mama bears, which helps us distinguish them from other pregnant moms with other diseases. Health department staff are also vital, specifically those that work with pregnant moms. That can include STD, hepatitis, Healthy Start, women, infant, and children, maternal and child health, and primary care. All of these departments will come across pregnant moms at some point, and all of them could be educating these mothers about HIV testing. Finally, you want to get community partners involved, which are your community-based HIV organizations that do counseling and testing. You want TAPA staff that outreach to high-risk pregnant women in 7 areas across the state. You want pharmacists, especially Walgreens that has been so helpful with their prescription baby express programs, and drug treatment centers that see mothers in all stages of the perinatal period and who reach out to our most at-risk pregnant clients that we have. If you educate all the healthcare providers above, then they can help educate all the women of childbearing age, their partners, and ultimately the general population. These next few slides explain more about what TAPWA and the Baby Express programs are all about. Here you can see a map of all of the current TAPWA contract providers in the state of Florida. If they are located in your area, you will want to be in contact with them to see if they can be a partner at your perinatal task force table. As mentioned earlier, their mission is to reach high-risk pregnant women that are not receiving services and link them into appropriate care. The Baby Express program links babies into care by providing the vital 6 weeks of AZT that they will need to have after their birth. This plan is to be the player of last resort to provide AZT for babies very quickly if no other options are available. Vouchers for that program can be obtained by a local HIV perinatal nurse or the HIV/AIDS program prevention section. And what should we teach? Well, we want to talk about basic HIV 101 information, depending on who we are talking to, and also the antiretroviral medication that our mama bears and their babies require during the perinatal period, when infections are most likely to occur. We also need to touch on risk factors for HIV and how the virus is spread through sex, blood, and birth. The percentages on this slide show the chances of acquiring HIV in those particular circumstances. Obviously, a perinatal risk without the mother being on antiretrovirals is by far the highest risk. The risk can be anywhere between 25 to 40%, depending on if it is a new uncontrolled HIV diagnosis during pregnancy, or a mom with a previous HIV history who refuses to take antiretroviral therapy, or she shows up at a hospital shortly before birth without prenatal care. That is why we place such a huge importance on educating healthcare providers and getting HIV mothers into care as soon as possible. Once the mother is on antiretrovirals and her viral load is undetectable, the risk of transmission to her baby is very small, around 1 to 2%. This slide shows the modes of exposures, or risks, that have been reported for cumulative pediatric HIV-infected cases here in Florida through 2015. As you can see in red, the child's mom having sex with an HIV-infected person is the highest risk factor to the baby. About 33% of the mothers are acquiring HIV by having sex with HIV-positive partners. Another category of cases is mothers that are injection drug users. They are 21% of this population. The other biggest part of this pie are mothers who we just don't know yet how they became infected, at 25%. More than likely, these mothers could be put into the heterosexual category, but we cannot be sure if some of them are closeted injection drug users or have some other risk. An interesting part of the slide is that 2% of these moms, in pink, were actually perinatal HIV cases, having been born to an HIV-infected mother. So the good news is that we have reached a time when antiretrovirals have allowed perinatal babies to grow up and have babies of their own. But the sad part about this is that those mothers who were HIV at birth went on to deliver babies that also were diagnosed with HIV. So somehow we failed to educate those mothers about staying on their antiretrovirals so that their children could live a life without HIV. This next slide compares the United States perinatal risk factors to Florida's perinatal risk factors. As you can see, they are very similar. Most of the children under 13 years of age are being diagnosed as a baby as a result of their mother being HIV positive during the perinatal period of pregnancy. So where are these HIV infections occurring in the United States? Well, as you can see, the majority of HIV cases are located here in the south, northeast, and western parts of the nation. This map shows us the rates in each of the states. Louisiana, Georgia, and Florida have the highest rates in the nation, in dark blue. When we stratify the HIV data on females across the United States by race, we see, in purple, that there is a huge disparity in the African American population when compared to all other races. We see this disparity in all parts of the United States, not just here in the southern region. So now let us turn our attention specifically to Florida. This slide represents the rise and fall of perinatally acquired HIV-infected cases in Florida from 1979 through our latest years of statistics in 2015. In the chart, you can see a percent change over the last 6 years. Up until the introduction of zidovudine in 1994, you can see there had been a steady rise in HIV-infected babies as more mothers in Florida had become infected with HIV over the years. But then in 1994 and beyond, the antiretroviral therapies that were introduced made a huge difference in whether or not a baby would become infected with HIV for life. There was a 91% drop in HIV infections from 1993 to 2015. The chart on the right shows the timetable of when certain perinatal guidelines and laws became enacted here in Florida. I noted on the arrow at the bottom showing where our perinatal task force groups began in Florida in 2002. So where are these babies being born here in the state of Florida? Well, I highlighted the counties in gold to show the areas that need the greatest support in helping our HIV pregnant mothers. Clearly, the counties in South Florida, of Miami-Dade and Broward, are the counties with the highest number of cumulative cases. But we also need to pay attention to Orange County, Duval County, and here in the Tampa Bay area where we are located. The most recent cases in 2015 are in light blue, and 70% of those cases were diagnosed in South Florida. When taking a look at the HIV-exposed newborns for 2015, we see that 505 babies were born in Florida to HIV-positive mothers. The majority of those births, 44%, were in southeastern Florida. I'm a big proponent of having a perinatal task force no matter what county you're in, but the areas in gold should definitely have some kind of perinatal task force in place to ensure that pregnant HIV-positive mothers are getting hooked up into HIV care and on antiretroviral treatment as soon as possible. So when are mothers here in Florida testing positive for HIV for the first time? Well, as you can see, a majority of the mothers, at 62%, are positive prior to the pregnancy. 14% are diagnosed during pregnancy, 8% at delivery, and 16% are diagnosed after birth. And that requires testing the recently born baby. So now that we have looked at the epidemiology of HIV in the population most vulnerable to acquiring HIV, how should we go about creating a successful perinatal task force team? Well, the first step is to determine who should be at the table. Who works with HIV pregnant females in your community or can help troubleshoot any problems that might happen with that particular group? The most important decision is to, of course, find or select a leader or facilitator. In our particular case here in Pinellas County, it was our HIV/AIDS program coordinator at the time, in 2002, that originally created and led the perinatal task force group for the first few years. But we soon learned that it was the surveillance office that was mainly ground zero for these cases, since many of the pregnant moms were being reported by providers or health department staff to our office, and we were trying to keep track of everyone on a line list. So it shortly evolved that it made more sense for me, the surveillance program manager, to take over the leadership and coordination of the meetings. Having said that, sometimes that arrangement might not work in other areas of the state. There might be someone else who either has the time or is better organized or has better connections to lead the group. But whoever it is, they need to be someone who everyone feels comfortable with that can listen to the summary of the mom situation and troubleshoot if there needs to be immediate action taken on particular situations. We can talk about that more when we discuss case studies at the end of this webinar. The next at your table can be whoever in your health department reports or works with pregnant HIV-positive females. In our case, we invite all of our HIV surveillance staff to participate and add any input they might have on that person. As for other team members that can be added from the health department, it makes sense to have someone there that can represent the STD department and the role they play with disease intervention specialists, better known as DIS. They're charged to go out and find all of these pregnant HIV-positive mothers. It is health department policy here in Florida that pregnant HIV-positive females get high priority with the DIS. They are supposed to track them down and make sure that they are not only linked into prenatal care and on antiretroviral therapy, but that their partners are also elicited from them and hopefully tested. In that same light, it is also helpful to have someone at the table that is part of the hepatitis team, specifically the perinatal hepatitis B coordinator, if your health department has one. In many cases, these women are co-infected, and so the HIV and hepatitis programs can share information and help each other out in their parallel investigations. Next, you want to have a Healthy Start or Healthy Families representative at the table, specifically one that works with or oversees other employees that work with pregnant females. In our case, we have a Healthy Start supervisor that attends most of our monthly meetings. If she's not able to attend, then we have someone with Healthy Start who works at our local CMS high-risk OB clinic, as they are the ones that can usually talk directly with the pregnant mama bear, or HIV-positive mom, and can find out what barriers the mother might be having in her prenatal care. If you have a TAPA representative in your area, then also make sure that they're at your table, as that can be an invaluable resource for you. So once you've looked within your health department and chosen the people you want to be at the table when the then the next step is to make sure you have someone on your team in the private sector that is a champion of HIV pregnant women, either in a high-risk OB clinic that sees a majority of your HIV patients, or if you're lucky enough to have one in your area, the best person to have on your perinatal task force team is a perinatal nurse coordinator who works directly with each pregnant HIV-positive mother through her entire perinatal period. Holly Beaver is our perinatal nurse coordinator here in Area 5, and she will talk to us very soon about what she does with these mothers. Finally, with the last three on the slide, you can add others onto the team from HIV infectious disease offices, CMS high-risk OB clinics, Walgreens Baby Express pharmacists, drug treatment centers, and any other interested parties. We have certainly reached out and asked these representatives to come to our meetings, but what we have found is that it gets harder to coordinate once we get past the core players that I previously mentioned. Many of these other healthcare providers are just too busy to attend, and that is understandable. So you need to determine who are the most critical people that absolutely have to be at the table, and then add on from there if you can coordinate a good time for everyone to meet. So after you've established the team, then you need to establish some rules and make sure that everyone is on the same page. Obviously, the most important thing is that you have to figure out who should be at the table for the entire meeting versus those that can come and discuss things at the beginning of the meeting and then leave so that the team can discuss specific HIV-positive mothers and what their needs or issues are, if any. If you're not sure who can sit through the entire meeting, then you might need to seek legal advice. But essentially, it is based on a need to know and whether or not that person would be working directly with the mom and would know about her status regardless of whether they are attending the meeting or not. These are going to be your core people I was referring to earlier. Most likely will be your health department staff and disease control, as well as Healthy Start individuals who work at the CMS high-risk OB clinic. It will also include the perinatal nurse coordinator, and if you're able to get them to the table, a representative from the OB high-risk clinic. All of these people will be establishing contact with this pregnant mother at some point along the timeline of her pregnancy. So bring them to the table and have them discuss what the mother needs. Next, you want to make sure that you tell everyone up front that anything you say or write in notes at the meeting is confidential, and they should keep those notes secured. Once they are through with the notes, they should be shredded or disposed of with other confidential health notes. You may be preaching to the choir, but also establish with the group the laws of the state on the boundaries you must remain within. For us here in Florida, there are two laws that allow us to collect information on these mothers and their babies. Florida Administrative Code 64D-3.029 and 64D-3.042 are two laws that you must become familiar with. They establish that providers must report newborns or children less than 18 months of age who are born to an HIV-infected mother within 24 business hours of the birth. The next law, 3.042, refers to the testing the providers are supposed to give to any pregnant mother they are aware of in their first and third trimesters. The mothers should be told what tests will be done and that she has the right to refuse any or all of the tests. But it should be done in an opt-out fashion to discourage mothers from refusing the test, as this is a test that can help us prevent the spread of HIV to her baby. If she refuses the test, then that should be documented in the chart. Finally, although in a perfect world, all OB providers would pick up the phone and call their local HIV surveillance staff and tell them about a pregnant mother with a history or new test for HIV, I can tell you from 20 years of experience that that rarely happens. We usually do not find out about these mothers until a confirmatory HIV test is done on them and it arrives in the surveillance office. If the mother has a history of HIV and no new confirmatory HIV test is ordered by the physician, then it becomes much more difficult as practitioners are not required to report HIV pregnant females. We then have to hope that the practitioner takes the appropriate steps and refers the pregnant mother to a high-risk OB clinic and hopefully a Healthy Start referral. Somewhere along the way, we have to rely on our colleagues in the health department or our perinatal nurse coordinator to make the surveillance and ultimately the perinatal task force team aware of these HIV-positive pregnant mothers so that we can discuss them at our meetings and determine if they have been linked into the appropriate resources in the community. When we talk about case studies at the end of this, you will learn that this scenario doesn't always happen as we would like. Sometimes we just get no warnings at all. So moving along, you then want to do the things you would normally do to set up meetings. Make sure that you pick a venue that will work for everyone and try to meet at least once a month. And then prepare. As a leader of the group, I always have an agenda, a sign-in sheet, and then I prepare a list of the pregnant mothers that I'm aware of. One list is for me, and then I use a shortened take-home list for the participants. In the list, I include the mother's initials to try to keep the confidentiality in place, the due date, and then comments on what the team already knows and what we still need to do for that mother. I also include any HIV pediatric exposed babies that have been born, and we try to discuss and ensure that the baby is receiving the appropriate antiretroviral medications and they are attending pediatric appointments to get their HIV PCR testing done. So the slide I have up shows an example of the form that I use for me personally, and then what I give out on the next slide. But you can be creative and use whatever works for your area. So here you have Mama Bear, Minnie Mouse, with her date of birth and the state numbers that we have for HIV and STD. We have her due date of this July and which clinic she's being seen at and when she's going to be visiting that clinic. We have that she met the perinatal nurse and also the Healthy Start representative, so that's good. And I also like to see over in the notes that she's on her antiretroviral medications of Camavir and Caletra, and her viral load is undetectable. But some things that we do need to talk about at the meeting would be that her boyfriend, Mickey Mouse, well, his status is unknown. So we need to go and have the DIS probably go and check on him and get him tested. The other thing is this is her 4th child, and we don't know about the status of her previous child. So we would be talking about that at the meeting. And then Donald Duck is her case manager. So we're going to go and call that case manager if we have to try to reach her and get her back into care. Okay, the next example is Princess Fiona. And she's got triplets of Fergus, Farkle, and Felicia. They were born at Far Far Away Hospital. We were really happy to see that the birth was negative, birth PCR was negative, as well as the two-week PCR. Unfortunately, she was missing in care. We couldn't find her. We suspect she ran off to Rapunzel's tower, but we don't know. So obviously I'm making light of all of this, but we can't use real names. But these are scenarios where if they're lost, we need to try to go find them and get them back into care and try to get those babies tested. Okay, so here is the example of what I give out to the participants. Again, all of the notes are there that we're going to be discussing that I just discussed, but I take off the names and we just have the initials. All right, so what are some of the problems that we have encountered as we created the group and have kept it together over the years? Well, the most important thing we needed to do is to get buy-in from all of the parties and let them know how important it is to have these monthly perinatal meetings. Since everyone at the table has some role to play in the life of this perinatal mother, then maybe we can help each other out in making sure all of the pieces of the puzzle get put together prior to the birth of the child. Everyone can assist in being part of the solution, whether it is throwing out some ideas or stepping up to assist with a particular problem the mother is having. We look at creative ways to solve some of the problems, and we can share some of those when we talk about our case studies at the end. If there's something we cannot solve at the table, then we make a plan to break away and take those concerns back to the departments we're from, and hopefully come back at the next meeting with a solution. This might include STD disease intervention specialists going back out in the field to try to talk to the patient, or the Healthy Start program might try to re-engage with the client if she previously told them she did not need their help. Sometimes it takes 3 or 4 attempts to reach out before the mother is willing to work with the team, and sometimes no matter what we do, we just cannot convince the mother to link into care. Well, at that point, we then have to go to Plan B and prepare the hospitals in the area that there might be a mother coming in that has not received prenatal care, and everyone needs to be on high alert. It is our goal during the months that we are aware of the mother's pregnancy to make sure that she gets in care and stays in care throughout her entire pregnancy. Hopefully that will lead to a successful outcome at the hospital and after the baby goes home. After each of the monthly meetings, a short summary is sent out discussing any updates that might be happening in each of the programs. And then the next month's meeting is placed into everyone's calendars with the understanding that anything new that happens with the mothers between now and then can be reported at any time. The three main problems that we usually talk about at our perinatal task force meetings are the mothers who deny their HIV status, the mothers who avoid prenatal care, and the mothers who avoid HIV testing on their newborns. Most likely, if you're having a problem with a mother not linking into care, it is going to be because of one of the three issues I've just mentioned. The solutions I've listed are what we normally try first, but we sometimes have to think outside the box. The first two are about mother on the front end of the birth, where we need to try to find and educate the patient or the provider about the laws on HIV testing, antiretroviral treatment, and ultimately stress that if steps are taken, then that mother can decrease the risk of HIV being transmitted to her child from about 25 to 30% down to 1 to 2%. Those are great odds, and the peace of mind of knowing that you did everything you could to help your child not have to live a life with HIV is extremely rewarding. That message has to be pushed over and over again to some of these moms, especially those moms who may be drug abusers or prostitutes. They may be afraid to surface because of the law or because they believe they will lose their babies. Although we cannot guarantee that that will not happen, it certainly will show good faith if the mother can prove that she did everything humanely possible to help her baby avoid a diagnosis of HIV while she was pregnant. So the key is education, over and over again. Sometimes we're very lucky and the mom agrees to put down her guard and work with the perinatal team. Other times it just doesn't work, but at least we tried. Occasionally we come across providers who have failed the pregnant mother. It doesn't happen often, but unfortunately we usually find out about it on the back end with the result of a positive baby. The surveillance office then has to do a thorough investigation, and these are some of the problems we have learned that were missed and led to a positive baby. Sometimes a third trimester HIV test was not done, with the provider assuming that as long as the mom was tested once in the pregnancy and she was negative, then that means she's safe for the rest of the pregnancy. This is obviously not true, as the mother can become infected at any time during the pregnancy. If a third trimester test is not done, then a rapid HIV test should be done before the onset of labor or at least before the birth. We will discuss a case later on exactly about this scenario. And then the last problem is that pediatricians do not understand that they also play a role in the reporting process. It is not just the OB doctors. We have had countless number of babies that were born and had their first HIV PCR test come back negative, and then the mom disappears after she leaves the hospital. She never resurfaces at a pediatric infectious disease clinic to get further HIV testing, or sometimes does not ensure that the baby has taken their full 6-week course of antiretroviral therapy. Primary care pediatricians need to ask new mothers if they are HIV positive, or if the baby was exposed to HIV, and then take action if the answer is yes. So now I will turn the presentation over to Holly, and she can share what she does to help make our perinatal team work so well.
Hello, everyone. We are going to talk about how we identify our HIV positive pregnant moms, but I want to do a little bit of a refresh as to why we're doing what we're doing. What is our goal? Our goal is that we have 0 HIV infected babies. Every HIV infant is a sentinel event representing missed opportunities. And so what we want to talk about is where are those opportunities and what can we do to go ahead and keep transmission from happening. Have we done everything possible, and what else can we do if we haven't? Mother-to-child transmission is estimated to account for greater than 90% of HIV infections in children who are younger than 13 years of age globally. This map is from the Journal of the American Medical Association Pediatrics, and it is providing us with new data because this was just published here in March of this year. And as you can see, the focus of the article is HIV infection among infants born in the United States. And as you can see, I've highlighted Florida there. We are the highest in the nation for HIV positive babies. So we have a lot of work ahead of us. We've got the highest numbers in the country. So let's try to turn that around. This chart I chose because it really shows and demonstrates the disparity between the races. As you can see, it highlights that greater than 50% of HIV-infected babies are from the African American community every single year. What are some of our common risk factors in transmission? And I know Beth and I are kind of repeating ourselves, but just an idea as to what we see are the issues that cause us to have HIV-infected babies. We've got maternal substance abuse, late, minimal, or no prenatal care at all, mom's denial of her status, refusing HIV testing in pregnancy, and then, of course, we always do a little bit further discussion with those moms, and then investigation as to why maybe she's avoiding testing. We see moms with mental health issues, and then maternal HIV diagnosis at labor and delivery is also a risk factor for transmission of the virus. This slide demonstrates the framework for elimination of perinatal HIV transmission. On the left side, you can see the problems that we have, missed opportunities. We've got an HIV-infected woman who's pregnant, but maybe doesn't get into care or is out of care from her infectious disease department or provider. She doesn't get preconception care prior to becoming pregnant. Perhaps maybe she avoids prenatal care altogether. We've got moms whose status are unknown but don't receive HIV tests during pregnancy. Inadequate prophylaxis. We can provide PrEPs to moms whose partners are positive to avoid her getting the virus or the baby being exposed. Cesarean delivery, which is necessary if the HIV viral load is above 1,000, and an infant who's breastfed because mom wasn't educated properly about the risks involved of transmission of HIV with that scenario. And then you do have children who, despite everything that we do, they become infected. Just wanted to review some of the significant HIV labs. If you don't work with HIV every day, they might not be part of your everyday vocabulary. The significant laboratory markers that I always discuss with my patients are the CD4 cells, which represent the amount of immune system damage. And also it presents and can tell us if there are risk factors for opportunistic infections. Our goal is for this level to be high, and I want that to be above 500 for my patients. The HIV viral load, or RNA, that I want to be as low as possible. And this is a predictor of the rate of progression of the disease, and it most impacts how mom's going to deliver her baby, vaginal versus C-section. My goal for all of my patients is to be undetectable, which is also less than 20 cells in a milliliter of blood that are affected by the virus. Here are our steps to perinatal success. We want moms to be in prenatal care. We want them to get tested. We want to make sure that if they have HIV, they're maintaining their medication adherence, keeping all of their prenatal appointments, and we want to follow up with mom and baby after the delivery. If the child is exposed, or what we call an E-baby, exposed to the virus, we want them to be on 6 weeks of AZT or zidovudine post-delivery. We also want to remember to educate mom that we have great resources in the United States, and breastfeeding is not necessary for these children. We can use formula very safely and effectively for these kiddos. We also want to provide birth control counseling to mom if she so chooses. And then any child who's exposed, any E-baby, needs to be tested at birth, at 2 weeks, 6 to 8 weeks of age, and at 4 months of age. So where do we get our guidelines? Where do we get the pathway to success for preventing the transmission of HIV to our positive moms? And here is a link that I wanted to provide you with. This is online, updated very regularly. The guidelines are very specific, going into detail about moms who've never been on antiretrovirals, moms who have been previously on antiretrovirals and how they can be diagnosed, counseled, and be given assistance throughout their pregnancy. And this, because the document is fluid and always is changing, I would recommend just accessing it whenever you have questions. It talks about intrapartum care and also care of an infant who has been exposed to HIV. I'm going to very briefly go over the guidelines, and I mean very brief, in 2 slides from a 300-page document. The guidelines, the briefest overview that I can do here are, my ideal picture would be that my HIV positive mom is undetectable when she conceives, and that her viral load remains undetectable throughout her pregnancy. For my newly diagnosed mama bear, we want to get her started on ARVs as soon as possible, with the goal being to get her to the undetectable viral load as soon as we possibly can. During labor and delivery, if medically indicated and mom can have a vaginal delivery, we can go ahead and do that if her 34-week viral load is less than 1,000. If not, and her viral load is above or equal to 1,000, then we need to schedule a C-section. A lot of providers like to do that at 38 weeks. And at that time, IV AZT is also administered to mom. This is given during labor and delivery. If mom's HIV status is unknown because she has not received prenatal care, we want to go ahead and do rapid testing during labor. And hopefully we discover what her status is prior to delivery, and then C-section is done and AZT administered as recommended. For the infant who is exposed, we give them 6 weeks of zidovudine at 4 milligrams per kilo orally twice a day. And then just a continuation, we've got to test that baby now that they've been exposed. We want to make sure that they have not acquired the virus, and we do that by testing them at birth. We do an HIV, DNA, or RNA PCR, if whatever's available in your facilities. We do a 2-week test, a 6 to 8 week test, a 4-month-old test, and then to make sure that they've cleared mom's antibodies, we test for the HIV 1 and 2 antibody antigen, a 4th generation, at the age of 2 years. So how do we link moms into care? Moms are identified by usually the health department team, and the disease control specialists and linkage coordinators are huge assets to our team. The disease control specialist will determine if an HIV mom is pregnant. Is she in medical care? They'll document any care providers, promote access to the HIV high-risk clinic quickly. A lot of times I'll get a phone call to help mom get into care quickly. They'll let me know, the perinatal nurse, by giving a referral form and encouraging mom to sign off on that referral. That allows me to contact her because I've got her permission. And then they document all this information in PRISM, and then they refer the client to a linkage coordinator. The linkage coordinator ensures that newly diagnosed and previously diagnosed pregnant moms have access to service. They work closely with the disease control specialist team and the HIV community-based organizations. They maintain current information regarding healthcare and social service providers, and then they make the appropriate referrals as needed for eligibility, the infectious disease care, HIV OB high-risk clinic, and make sure that they get their appointments. And here's kind of a wheel of progress as to how this all works. The linkage staff and DIS coordinator will engage the newly diagnosed or fallen out of care mom to establish goals with her, getting her HIV education regarding our plan of care to prevent transmission. They'll link the mom into care and treatment, confirm that she's received the services that were recommended, and then they follow up with us at our monthly task force meetings to discuss any issues or barriers that we need to work on. And this is a never-ending cycle. It's happening throughout the month and being discussed monthly at our meetings. So what is my role? As the perinatal nurse coordinator, I provide comprehensive case management services throughout the pregnancy, provide intensive mom and family education regarding the plan of care and what we can do to decrease that transmission risk. I facilitate infant referral to the pediatric infectious disease specialist, and then I assist with obtaining the AZT or zidovudine for the infant. The infant is then followed to assure that all the testing is done and that HIV transmission has been rolled out for these kiddos. So who are our referral sources? Our referral sources are OB providers, the infectious disease providers, primary care physicians, and then mostly I hear from the Florida Department of Health. The surveillance office will notify me when we have an HIV positive mom, as well as the DIS or linkage coordinators. It could be the pharmacy who's providing ARVs to somebody that they know is pregnant, and then the team at Healthy Start who also is at the task force meetings. And then I like to make sure that I've connected with the appropriate staff as far as the OB department specifically at hospitals and in our local OB providers in town. The packet that I use includes a letter of introduction and kind of tells them about our perinatal team, as well as includes some articles about perinatal transmission. And then I always give them a stack of my referral forms, and then the Department of Health has those referral forms as well. So when the DIS coordinators are out in the community, they can hand mom a referral form. She can fill that out, sign it, and that gives me permission to contact her. And here's a copy of my referral form. As you can see, it's just basic information, mom's name, address, contact information, and that's just her approval or agreement to be in our perinatal services. And you can see at the bottom, this form is either faxed to me or my coworker, Maite McLeod, who is also the perinatal nurse coordinator for Hillsborough County. Now I want to talk about developing the relationship with our mama bears. I like to make the initial contact with mom, preferably in person. It's, I think, a lot better to be able to present a face and a smile and attend an OB appointment if possible. If an OB appointment can't be attended, I can arrange a meeting in my office to go over things with mom. But I do have moms up in Pasco County that I don't necessarily have the opportunity to go to their OB appointments. So I then contact them by phone and stay in touch a little more frequently to see how they're doing. We've got two specific types of referrals. You've got the mama bear who's positive, who's possibly had children before and know the plan of care, know what to do to keep her children from acquiring the virus. And then you've got a newly diagnosed mama bear. One of the things I like to do after establishing that relationship is to determine the needs of each parent. If mom is infected prior to conception, I like to check on the status of her ID care. Is she seeing her infectious disease specialist regularly, getting her labs done, and staying on meds? And if she's not in care, then I work to get her into care as soon as possible. And then also checking in on the status of her OB care. Sometimes I have to help coordinating getting into care, especially with our high-risk clinic. They're very busy and they don't accept patients just off the street. Sometimes it takes a call from me to get mom in the door and get an appointment. And then I check with her on previous children. Have we completed their testing? If not, let's get them in to be seen and evaluated and make sure that their testing is complete. For the newly diagnosed mom, I'm going to spend a little bit more time providing support. It's a very exciting time of pregnancy, but then very upsetting, shocking to find out that you're also HIV positive and carrying a baby. So I'd like to provide a lot of support to these moms, making them aware that I'm available anytime. They can call if they have questions or any needs, and I will assist to help them in any way that I possibly can. I try to get them into infectious disease care as quickly as possible. The OB physician can provide the ARVs that they need, but I want to make sure that they continue in care after delivery to keep themselves healthy. A lot of times these moms have to transition to a new OB physician. If a prior physician has diagnosed the HIV, especially in our area, we only have one provider that will provide OB care in Pinellas County to moms who are HIV positive. So not only does mom get this news, but she also has to go to a new provider. So I coordinate getting her into the new OB physician as quickly as possible. I educate her about HIV and then talk to her and follow up with her to make sure that she's gotten on her ARVs, if she's having any side effects, what she can do to manage them, and any opportunities or options for change if the medications aren't working for her. I also provide moms at the initial meeting with a Mama Bear packet. And I just wanted to give you guys a brief overview of the contents of those packets. The letter of introduction to the perinatal program describes basically what we're about, what we're doing, and our goal, which is to have a baby who is healthy and does not have HIV. I provide them with a brochure that was produced by the University of South Florida called Pregnancy and HIV, What You Need to Know. I give them contact information for our whole pediatric infectious disease team, as well as a map to our clinic, as well as my business card. And there's just a picture of the brochure that I include in the packet, Pregnancy and HIV, What You Need to Know. And this just reviews the entire plan of care for a mom who is pregnant to reduce the risk of transmission. Just talking really quickly, I'll go through what we do to educate our moms. I review their HIV education if they're previously infected, go over the plan of care and how we prevent transmission, review with her the important labs, her HIV viral load that we want to remain undetectable, and her CD4 count. And remind her no amniocentesis during pregnancy or internal monitoring. And the form of her delivery, vaginal versus C-section, is strongly based on the viral load in her third trimester. Obviously, there are other medical issues that can play into that, but if she's shooting to go for a vaginal delivery, her best bet is to stay on her ARVs and remain undetectable. Continuing that education, we go over the schedule of HIV testing of the infant. We want to test them again at birth, 2 weeks of age, 6 to 8 weeks of age, 4 months, and 2 years. Reviewing the plan of no breastfeeding. Talk to her about her birth control plan, and then answer any questions that she may have at that point. For the newly diagnosed mom, we go over HIV, the transmission testing, CD4, what it is, where should the levels be, what are our goals for our CD4 viral load, what is it, and what is my goal, and my plan of care for preventing HIV transmission.
Hey, Holly?
Yes.
Just want to give you a heads up. We've got 5 minutes.
Okay. So let me just skip through then. I'm going to go through the monitoring really quick. I just watch mom's labs throughout the pregnancy and communicate with her. I visit at the point of delivery and then go over with her the schedule of testing for the baby, which I do here, give her the test dates. I also give moms a calendar with the dates of how long the baby is going to be on meds. And then I review all of this information at the follow-up when we see the infant for testing. So I'll let you look at those together. One of the best parts of the job is celebrating with mom and family when the babies test negative. Again, our goal is 0 infected babies. Just wanted to review a couple of case studies with you and how the team came together to prevent transmission. And we did have one mom who came from overseas and presented to the OB office at 34 weeks pregnant, who came in with an empty bottle of Atripla, reporting that she took her last pill that day. This was a time that I got a phone call and then referred to a local community-based organization that I knew could get mom into care and get meds. We came together the next week at the task force meeting and found out that this mom had not gotten into care as of yet. So we came together to go ahead and make sure that she did get into care at the task force meeting. At the monthly task force meeting, we probably spent about a half an hour on this mom, putting our heads together. And the first thing we had to do was determine that she was HIV positive, because in this country we didn't have record of that. So the Department of Health came together and said, we're going to get her tested here, get those results back quickly so that we can get her into care and get her back on ARVs. So what we went ahead and did is the USF team was able, the social work provided through CAF, the Children's AIDS Foundation, an Uber. Mom had a half an hour ride to get to the Department of Health for testing. So we were able to provide her with that transportation to get here. The team then discovered she was homeless. So throughout this whole scenario, we were hitting roadblocks with this mom. It turns out she ended up delivering her child out of state But thankfully, we can report that that child is negative due to the quick work and action of the perinatal task force team. My second case study was a mom who was diagnosed during delivery. This mom had no prenatal care. Again, she was from overseas. This was her third child. She had made 2 attempts to get into care but was unsuccessful in doing so. She was diagnosed at delivery during labor and was given an hour and a half of AZT before her C-section. The hospital contacted the Department of Health. The Department of Health contacts me, and then I got in touch with Dr. Rodriguez, our infectious disease specialist, who then got on the phone with neonatology at the hospital and got the baby on a 3-drug regimen because this is a high-risk infant. Walgreens was our savior because they were able to deliver medications to me in clinic when the child had been discharged without medications in hand. And mom has now been linked to ID care, and I can happily report that that child's 2-week birth test or 2-week test is negative. I do have a case study. I'm going to skip over some of them. From a mom who had a previous child, was infected prior to pregnancy, followed all of the suggestions of the perinatal team. Unfortunately, at 37 weeks and several days, she did go in to be evaluated for what she described as wetness in her pants. She was evaluated for rupture of membranes. It was determined that she did not have a rupture of membranes, and then went on to deliver her baby 24 hours after via C-section. The birth PCR was negative, but then unfortunately that baby did test positive at 2 weeks. So even though sometimes we do everything we can, it doesn't always turn out the way that we want it to turn out. So I wanted to give maybe just a few minutes for question and answer. Again, putting everybody together on the team is a vital part of keeping transmission from occurring to our moms. Just go through a couple of acknowledgement and resources that you guys can look at previously. Well, thank you all. Hopefully we were able to answer everything. And again, we're both available. So if you have questions, you want to shoot us an email, don't hesitate.